Okay. So, supporting children with complex disabilities and their families. And I put that into the title, and then it made my title look just huge. But and their families, because we need to be thinking about parents, all the way through what we're thinking about today. So, full disclosure, I work all over the place. I'm a salaried employee of Simple Stuff Works, and they make nighttime positioning equipment. I'm a director of Goldsmith and Goldsmith, and I provide measurement of body symmetry and consultancy to privately funded clients. I do that in the UK and overseas. I do lots of face-to-face training with Born at the Right Time, and I do lots of online stuff. And I'm one of the clinical experts at Clinical Excellence Online, which is a coaching platform which supports paediatric OTs, physios, speech and language therapists who are working with children with disability from all over the world. So that's me. But more importantly, I had the best socks in the world growing up. Look at the state of those bad boys. So I grew up with my mum and dad, as Bernie so kindly said there. My dad, my mum calls herself a recovering physiotherapist, and my dad was an engineer, and he was a weapons and explosives specialist in the British Army. And there was no way I was going to escape postural care. Okay, I grew up in it. I tried really hard. I became a teacher for 5 years, and I got dragged back into it. So these are just some of the things that I've been involved with over the years. There are probably students, and I'm going to say students. I know that there are graduates and fully qualified clinicians out there that weren't born in 1998. So I've been around for quite a long time. So we are going to think about just a definition of what postural care is to give us all an idea of what we're thinking about, identify some key components of postural care. We're going to think about some practical strategies for nurses and for families who are starting to look into this work. We'll identify some common challenges for those that are providing postural care, and I'm going to signpost you. There is such a huge amount of information out there, and some of it's better than some. It's like everything on the internet. Some of it is better quality than other stuff. So I shall signpost that to you. So what are we thinking about? What I might do for 1 second, let's just go into here, and have I lost you again? There we are. Am I back with your screen now?
Sarah, for me, the slides haven't moved on yet. I don't know if that's the same for everybody else.
Are we there now?
We're still on the brief history.
No, still on the brief history.
How are you?
Still looking at your socks. They're that good.
I think Sarah's frozen now. I think we've broken teams with everybody on the call. Apologies, everyone. I think Sarah's having some connection issues. She's frozen on my screen, so we'll just wait for her to come back into the room.
Has she left, Simon?
Yeah, she's gone now. Okay. So hopefully she'll be back with us, everybody. Shortly.
I've got her on WhatsApp if we need to contact her that way. I think one of the things that
Hello.
we were doing was
Hello,
asking
everyone.
people. Hello.
Hello, everyone.
Oops, there's Sarah.
Here she is.
Yeah. If people want to make a note, those who haven't, of what their discipline or speciality is, as well as perhaps where they're calling it in from in the chat, that would be great. That just is helpful. Only if you want to, no pressure. Back to Sarah. Here you go.
I'm back. I apologise. I was thrown out. So can you see my screen now?
Yes.
Yes.
That says session objectives.
Yes. And then if I go,
Perfect.
can you see it now?
Yes.
Ah, there we go. Oh, that was a little heart stopper, wasn't it? So
Yes.
if we're thinking about what postural care is, people talk about 24-hour postural care, and then I tend to focus on lying. So if we think about an overall definition of postural care, it is continuous support of a person's body, both during the day and at night, to protect their body shape, to improve comfort, prevent complications such as pressure injuries and contractures. So it's basically, if somebody finds it difficult to move, then they are vulnerable to the effects of gravity. And when we think about children, and we think about who in the world of paediatrics, who should I be thinking about? We use something called the gross motor function classification scale. And that gives us some broad definitions. You can look these up and you'll find this diagram all over the place. But when we think about postural care and those vulnerable children, it's those children at GMFCS 3, so which is these guys here, 3, 4, and 5. And the more limited a child's independent movement, the greater their risk of changes in their body shape and secondary complications. And when we think about how prevalent those changes in body shape are, just taking a look at the risk of hip dislocation for children as relating to their GMFCS level, what we see is that when we come to kids with GMFCS 4 and 5, the chances, they have a far greater chance of experiencing hip dislocation than not. And that's massively challenging, because hip dislocation is not a pleasant process to go through, and it has huge implications for a child's seating. Once you start having implications with regard to seating, it will affect education. All sorts of different things start to come into play. And so what we need to be thinking about is, are there ways that we can prevent some of these changes in body shape from happening? So introducing the concept of nighttime positioning or supported lying, so whether that's the day or the night, that's the earlier we can do that, the better. And it's really important to recognise that the introduction of supported lying is not something that happens to typical children. And it isn't something that parents who have not had experience of childhood disability will have experienced before. So if you think about an intervention such as a wheelchair, whether or not you have a disabled child or not, you probably know what a wheelchair is. You've probably seen somebody using a wheelchair. So you have an idea that this world exists, the world of wheelchairs. But unless you have first-hand knowledge of somebody with complex disability, you probably don't know that supported lying exists. And that's really important to recognise, because there isn't a general awareness in the population that this is something that these families need to think about. It's not something that practitioners realise that they need to think about. So this is just a quick animation just to help to introduce the idea to parents who have no idea that this world exists.
On an ordinary town, in an ordinary street stood two houses, number 22 and 24. Both homes brimmed with expectations, dreams of first steps, playing in the park, maybe one day graduation. When a baby girl arrived at number 22, it was blazing with balloons and banners and great joy. But the boy at number 24 had a rough start, and his parents loved him through a plastic box, cloaked with fear, surrounded by monitors and medics. When he did come home, he was welcomed to number 24 with balloons and banners and great celebration. As night fell, both homes learnt their new normal of broken sleep, little sleep, and absolutely no sleep at all. For both families, questions and delight abound. At number 24, the diary was filled with appointments, visits to the doctor, medications, ambulances. At number 22, sitting turned to crawling, crawling turned to walking. But for the boy at number 24, he needed support when standing, help when lying, and assistance sitting. In every position, he had to be held like a newborn baby, until one day he got his own specialist seat. One that supported his pelvis, chest, and head, keeping him in line. Like a precious sunflower reaching for the sun, he needed constant support to keep him growing straight. But then nighttime came, and those at 22 and 24 were in bed 3 times longer than they were at school. And through all that time, gravity pressed down on the boy at number 24 in whatever position he was in. Where the girl at number 22 wriggled, turned, twisted, and fidgeted, time, gravity, and reduced movement conspired to squash the boy at number 24 so his hips rotated and spine twisted. That was until professionals and his parents made simple stuff work. So while the boy at number 24 was sleeping, they supported his sides, knees and legs with kindness and a supportive sleep system. While his growth hormones were silently being released, his muscle tone relaxed. They used gravity, time, and his reduced movement to keep him symmetrical, secure his pelvis in line, keep his hips and legs neutral, and his spine straight. 3 simple things that could change his life. I didn't expect to become a resident of number 24. No one does. I hadn't planned on learning about medications, therapies, or postural care. But I take the information I'm given, along with the challenges of real life, and do the best I can. Because as a parent, I can make a difference to my son's future and quality of life.
Okay.
On an ordinary...
I'm going to watch it all again. So what we're thinking about is supported lying as what's often a missing part of the puzzle. So we are aware of seating, we know about wheelchairs, we know kids use standers, but if we don't think about supported lying, it means that we haven't closed the loop. And unfortunately, supported lying, the lying position, is where we all, well, kids, particularly kids with complex disability, spend the most time. If children experience changes in their body shape, it can have an impact on every other element of their life. I always think about the supported lying position as the foundation stone upon which everything else is built. And if it's missing, or if it isn't quite right, everything else, whilst it may well happen, it won't necessarily be as good as it could be if we had that good foundation. So, for example, movement. It may be more challenging for children to develop their independent movement skills. Dysphagia and the risk of aspiration. If a child develops a scoliosis, we know that people with learning disabilities, one of the biggest causes of premature death is dysphagia and aspiration pneumonia. So all sorts of things come back, and it may not be our role to understand supported lying and to prescribe equipment and those sorts of things. But we do need to have a knowledge of it so that when we are supporting somebody with complex moving and handling, for example, we know to ask the question, is this person's lying being considered by the OT, the physio, whoever it is that's local? So The key components of postural care, we could think about them in terms of positions, but let's think about them in terms of these areas. So the first one is daytime positioning. So sitting, standing, lying, and mobility aids. The second, and the one that potentially is one that people don't know as much about, is about nighttime positioning. So what happens for that huge chunk of time? The next, we think about transitions and movement and promoting regular changes of position. We also need to think about movement and access to mobility aids with regards to supporting children's learning and development. If kids can't explore their own environments independently, then either the world has to come to them, or we need to think very creatively about how we're going to get them mobile. So that's another part of postural care. And then finally, and I've put it in a section all on its own, but we finally have the equipment side of things, because most children will have an absolute shed loads of equipment and assistive devices and things that either we need to find room for in the house, or they're used in school, or they're used wherever, in hospital. But the equipment and the systems around equipment provision are really, really important. So we could think about, like we've thought about there, the general components of postural care. And we could think about postural care with regards to the components of a postural care service and different parts of that service that all need to work together. So firstly, we've got to identify the kids that are, that need protection of body shape. But once we've identified those children, we then need assessment and identification of shared goals with the family. And those goals, and with the child, those goals are going to change over time depending on why the person needs some therapeutic positioning. We need to think about equipment provision. We need to think about implementation, and under implementation, I would also add all of the training that goes in to understand why you're using a particular piece of equipment, as well as, what goes where. And then we need to have really robust review processes, so that is that equipment and the implementation of that equipment working to meet the identified goals of that child and family? And we go round and round and round in circles. Now, what I'm going to share now is I've put there at the bottom that changes in body shape are highly predictable. And with predictability comes an opportunity to track a different course. So I shared with you that graph looking at just how many children at GMFCS 4 and 5 experience hip dislocation or are at risk of hip dislocation. And we need to think very carefully about, if these changes are predictable, are we doing enough in order to avoid some of the experiences that these children and families are having? So with opportunity comes the responsibility to explore every avenue to see if we are getting this right, and to be big enough to say, there's more that we could do things differently, etc., etc. So I'm only going to share, I'm not going to go through, as I said before, I'm not going to go through all the different patterns of distortion. That's a different webinar. But what I wanted to share with you is some of the material that we would use when we're training physios and OTs, and to share it with you as nurses and as family members, so that you can see the sorts of things that we would be talking about. So this is a pattern of distortion, and it's called windsweeping, and it happens in all unsupported lying positions. So to be really clear, windsweeping does not just happen when somebody is lying on their back. It also happens when they're on their side, and it happens when they're on their tummy. And what we do is we think about that pattern. We have to identify the pattern that the child is following. And then we would use specific positioning techniques in order to either correct the child's body shape, or if that's not possible, if a child can't move out of a particular position, say, for example, side lying because of a aspiration risk, or, risk of vomiting, etc., etc., then we look to provide maximum support whilst recognising that we can't necessarily be correcting that child's posture. So with windsweeping, if you take a look at this picture here, what we're able to do and what we teach clinicians to do is to identify what are called bony landmarks to help them identify the pattern of distortion that that child is following. And before we kind of, there aren't that many patterns. Okay, I'm not only sharing a bit because there's like an encyclopedic textbook full of all different patterns of distortion. The patterns are very, very, once they become familiar to you, they're very easily identifiable. So what we do to identify the pattern of distortion is we will look to see where the pelvis is. So we find the two bony bits at the front of the pelvis. We look to see where the lower ribs are and whether there are any shapes. Can you see that we have a shape here that's a bit unusual compared to here? So we look for asymmetry in the chest shape, and we look to see where the sternum is. And we come back all the time to think about what is typical. And typical is that we have a level pelvis relative to the horizontal. We have an even gap between the lower ribs and what's called the ASIS or the ASIS, the bony bits at the front of the pelvis. So we should have a nice rectangle here, and the sternum should be in the middle. And if you look, each of these young people is following exactly the same pattern of distortion. So they are all what we would call windswept to their right. So their legs are going over to their right, and their chest. The way that we talk about this with families is we talk about the chest. We have an imaginary line inside the chest that connects the sternum at the front to the spine at the back. And we imagine that line as a tower. And when a child is lying down, that tower should be upright. So hopefully, if you're imagining a tower in each of these people's chests, then hopefully what you're starting to see is that these towers are not upright. These towers are falling over. And I want you to imagine a big, heavy weight at the front of the chest. This child cannot move out of this position. They don't have the movement repertoire that they need to defend themselves against gravity. And so if you imagine that the chest is just sliding over that way, what we have is a rotational distortion within the chest that is highly, highly predictable. But we need families to know what to look for, and we need every practitioner that supports these more complicated kids to know what they're looking for. You don't need to necessarily know what to do, but you do need to know that there is something happening. So as soon as children move away from typical, there is something happening, and you need to know who to ask for help. So positioning techniques that we might use, this child, their tower is falling over in the opposite direction. This young person is windswept to their left, and what we'd be looking at here is a clockwise rotation in their chest. So what we need to do is we need to think about how do we get this person's tower, that sternospinal line, how do we get it upright? And the way that we do that, before we do anything, we say to the parents, look, we've got a bit of a rib flare here. So what we're looking at here is where this little boy's chest is conforming to the supporting surface. Gravity comes straight down. And what we need to do is get his sternum, because look, his sternum is not in the middle. Typical, the sternum is in the middle. So there would be an even gap from here to here. And from there, look at that, all the way over to there. So can you see how we're just rolling round? So we need that sternum in the middle. And the way that we do that is we support this side, we roll the chest to bring it round, and we get the sternum in the middle, and then we support the other side of the chest. And that rib flare that we highlighted now becomes really, really obvious. And if we hadn't talked about that before we were to do this, that would be terrifying. You know, like you think that your child's chest, you're not used to looking at chest after chest after chest. You're not expecting this. So we need to be using our experience to pre-warn families of what they might see, and to be really, really clear that everything that we do, they are 100% in control of. They and the child are the only people that get to decide whether they're going to do this and how long they're going to do this for, because they are doing it on top of lots and lots of other stuff. But the exciting bit about supported lying is, and I think I said in the promotional blurb for this webinar, is you've got 3 times longer in bed than you have in school to mess about with. So if we get it right at night, bodies are soft and squashy. And if we get it right, can you see bony landmark stuff? So hopefully already you're starting to say, right, she told me to look for the sternum. Well, the sternum's here. She said I've got to look for the distance from there and all the way over there. So I know this guy's tower is falling over towards his right. So we've got to keep getting that tower up. I'll support this side. We give that roll. We get that sternum in the middle. And this is him 3 months later. Look at where the sternum is. Can you see how we're shifting back towards typical? We're shifting back towards a central sternum, which is what we want. This was an absolute disaster because this young man is 25 years old and the photographs, as it says, are taken 3 months apart. So we're seeing these big changes happen very, very quickly. I'm going to leave it with you as to whether you think that the system and everybody around this young man is going to be able to move quickly enough to get his seating adapted, to get his shower chair adapted, to get all of the other things that are custom to him changed in response to his changing body shape. Whilst the photographs look great, it was a huge lesson for me. And this is about 15 years ago. This was such a lesson in terms of communication and making sure that before we do anything, we've thought through what the possible implications are. Okay, the last 2 that I want to share with you is just to take a think, because a lot of you, if you're, depending on your setting, you will be supporting children in lots of different places. But for those of you that are in an acute setting, you'll see lots and lots of kids in bed. Maybe not so much if you're a school nurse, but who knows? So what we need to think about again in terms of predictability. So whenever I'm looking at anything, I'm looking, I wish I had X-ray vision sometimes, although you just start to be unable to think about hip joints when you see people's lying postures once you've been around the block a couple of times, as I have. So in terms of predictability, this person's legs act as a lever on the hip joint. And for children who don't weight bear and who don't get that impact of crawling and cruising and then walking, the hip joint isn't necessarily as robust as we hope it would be. So we know that kids that don't weight bear are potentially at higher risk of hip dislocation, but the position that we have the legs directly impacts what's going on here, doesn't it, at the joint? So if we leave the leg to fall across the midline, so to turn in, then we can predict that we're going to get what's called a posterior dislocation of the hip. All right. So the weight of the child's legs is acting as a lever on the hip joint. The predominant thigh posture acts as a lever here. And if we have the leg falling away from the midline, then we're going to be acting as a lever, and we potentially are promoting anterior or a forward dislocation of the hip. And so the answer is that we can't allow the legs to act as a lever on the hip joint. And it sounds really simple, and we're going to come to the barriers at the end, but this is massive. The implications of these, the implications are huge for the child, but the implications are huge for the family as well, in terms of the more complex a child's body shape, the more challenging their care needs may be, things get harder, and that is not what any of us wants. So we come back to that risk of hip displacement, and we start thinking, are we getting it right with regards to those potential lying positions? If the predominant, so there was a paper last year, which I'll share in the resources for this presentation. There was a paper last year from a group of surgeons in the US, and it cited predominant thigh posture as one of the determining factors in terms of hip dislocation. They then went on to say that tendon release, so a surgical intervention, was a kind of an indicated, whereas I was pulling my hair out saying, well, if predominant thigh posture, before we do a tendon release, please could we look at where we're actually supporting these kids' thighs. Okay, so some practical strategies. First thing, if you are a family or a nurse or someone that's starting to think about this for a child that you support, first place to start is to just get an idea of what is the situation that you are in. So this is there's a great organisation called Medifab, and this is one of their educational resources. And you just colour code where the person is spending their time and what equipment they have. And it helps you just to identify if there are any gaps. So if we've got somebody that goes to bed, let's see if I can mess up. Let's see if I can throw myself back out of the room. So let's say that the child goes to bed at 8 o'clock. Okay, so that's where they start their nighttime. They don't have a positioning system at night. They use sideline, which we know is a potentially destructive position. There isn't a safety reason why they're using sideline. It's just that they didn't, the people around them didn't realize that it can be destructive. So they then get up. Let's say that they get up at 7 in the morning. So we come right the way around to here. Well, I've given them 7:30. They've had a lie-in, right? So we come all the way around. And if we were to be bothered with shading that whole space in, can you see what a huge chunk of time potentially where a child is at risk of harm? So now let's see if I can erase all in consult. There we go. So this is a great tool for just working out where you might be prioritizing your time. A stander, and I'm not saying, at no point must anybody be thinking that I'm saying, oh, don't bother with standing, lying's the answer to everything. I'm not saying that at all. What I'm suggesting is that if a lot of time and energy and money is being spent on a stander, that's great when you've got some of the big chunks of time well covered. So it's not don't do things, it's make sure that you've got some perspective on that 24-hour situation. So for nurses, there are some brilliant tools out there. So this tool that I've shared here is an overview tool for learning disability nurses, and it was developed by a guy called Piers Baker, who is an absolute superstar physiotherapist when he was working at Leonard Cheshire. And it's a fillable PDF, free to access. Again, the link is in the resources at the end, and it's there for that information gathering. So it's great for families as well to help you to gather your thoughts before you're sat in front of the clinician that you need to talk to. Okay. The next thing to do is find out who your local postural care person is. Okay, so it's probably a physio or an OT. And then you need to be their friend. Okay, if cake's their thing, then that's what you do. So find out what the local system is. And I did a quick search online this morning for our local provision, and I'm in Staffordshire. I found all sorts of information about their local postural care services, who to contact, etc., etc. So whether you're a family or whether you're one of those clinicians, find out who that person is and get to know them. The other person you might want to be chatting up is your local equipment store. Okay, find out what equipment's available, what's on stock, what's there that you can easily access. Take photographs. These 3 photographs are absolute gold dust to somebody like me. So I want to know what's your young person's preferred lying position. So the preferred lying position, where do they spend the majority of their time? And for lots of kids, if they do sleep on their side, you might want to get one on one side and one on the other. So if you were to think in your mind, and I'm talking to parents here in particular, if you were to think, oh, that one's really familiar to me, that's like in your head now, how does your child sleep? If there's a position that comes to you, that's the one I want. All right. The next one I want is this one. I want to be able to see those aces, so those bony bits at the front, and I want to see those lower ribs, because what I'm interested in, let's see if I can do it without messing everything up. What I'm interested in is the No, I can't do it without messing everything up. I'll try again. I want to know what's happening here and here. And Sharon Sutherland, who is a legend of a physiotherapist, does on YouTube, you'll find a thing called the Life Box, which is from Sharon Sutherland. And she talks about protecting this area in lying and in seating. Okay, so we need this relationship. And the last thing I want to see is I want to see what's happening in terms of chest shape. So I want to know, I'm looking at where the sternum is, but I want to know, are there any lumps and bumps that are appearing in your child's chest that ideally would not be there? Okay. Right. Last couple of bits now. Oh. Next thing to think about in terms of practical strategies, you need to make the link between lying and sitting, and then between sitting and life in general. Okay. Which of these positions, and it's not a trick question, which of these positions aligns with this position? If there's a really big difference between this one, remember 3 times longer in bed than in school, and this one, then this transition between these 2 positions is going to get harder and harder and harder, and this one will win. And it will win for lots of different reasons, but the biggest reason is just time. Okay, this is thousands of hours of the year. So make that link between lying and sitting. And as I say, then make the link between sitting and the really important stuff. So you should all know the F words. Okay, fitness, functioning, friends, family, and fun. So these areas of a child's life will be impacted by their body shape, and we can use the ICF framework to help us to think through the way that we justify, clinically justify looking at positioning. Last couple of things to share with you. So just want to quickly introduce you to Taylor. So this is Taylor, and this is my beautiful girl, and I'll tell you a little bit more about her in a little bit. But Taylor's not a GMFCS 4 and 5. Taylor's immobility when he's lying comes about because, I usually lie like this, is not because he can't move. It's because when he adopts other positions, he's not supported enough. So his legs, when he lies on his back, there is not enough support around his legs. And so there's nothing for them to rest on. So it's just not a position that he's able to adopt. So this is just a positioning system. I'm not going to go on about equipment, but I just want to show you that loads of the instinctive stuff that families do and nurses do and physios and OTs, those instincts that you have of propping somebody up and of trying to hold somebody when they're in bed, those are, your instinct is spot on. What you might need some help with is holding that positioning in place, because pillows and towels and teddy bears and things like that, they tend to move and they tend not to give people the security, the stability that their bodies are looking for. So we've got Taylor beautifully well supported underneath. So all of this gubbins here is underneath a sheet. So his bed looks like a typical bed. And then what we have is a WhatsApp group, because we need to be finding ways of really quickly responding to people's experiences. So let's have it now. Let's see. I don't want. So let's see. Will that play? Will it play? It won't play. It does. How do I laser? Oh my life. I'm not even going to do it.
Press off the laser.
Say again.
Go back on the laser bit. Press.
Yeah.
Just come off it. Erase all link on slide.
Erase all link on slide. Yeah.
And then click off the slide. Oh, it's still laser. Okay, sorry, I don't know.
Yeah.
You need that,
but do you know what? I so appreciate you trying to help me. I really do. So this is a WhatsApp group. And in that group, the first one, this one here is him saying, I'm in it and I'm all snuggly. And then the next one is the morning after. And he says it was a different night's sleep, but amazing. So finding ways to cheerlead kids who are trying to make changes in their lives is so important. You know, and it just can make the difference. The speed at which we can, in a WhatsApp group or very quickly being able to get online, the speed at which we're able to say, you know, I had a really bad night. Right, I'm here. What can I do? What happened? Let's think about how we can resolve this. Because if we don't resolve things quickly, people will struggle on and then they will give up. And then no matter what you do, they're like, no, thank you very much. Don't come anywhere near me with that.
I've just got into bed now. It was a different sleep. It was amazing.
Did you hear him? Right. Okay. The reason that we need, so I'm not looking around for somebody that I can position just because I got nothing else to do. I'm looking because, what did we say? We were talking about the F words and we were talking about life in general. Taylor wants to be up on his prosthetics. And with his center of gravity, why I've got a laser, I've no idea. With his center of gravity so far forward, remember he was on his tummy. So being on your tummy, the lumbar spine drops forward and we end up with this long lordosis. His center of gravity is forward. It makes him unstable. It puts lots of pressure through the front of his legs on his orthotics. In shifting his center of gravity back, we make this whole situation down here more sustainable. All right, he can spend longer on his legs. His function is better on his legs. So it's, you know, and this is six. So the other thing to say, so this was 6 weeks between these two photographs. All right. And everybody loves a before and after. And they want something dramatic. And it's like, oh my God, yeah, that's amazing. But actually, when we think about other experiences that Taylor's then gone on to have, so he's had this really positive experience. At the beginning of this year, he was having more surgery. You know, it's not that if we position people well, everything's going to be fine. It's that positioning plays a part in that big jigsaw puzzle that is these complex kids. Okay. So the common challenges for those providing postural care, and within this, those providing postural care slide, my heart goes out to OTs, physios and nurses who are in the system trying to get this right for families. So it's not just the families that are finding this challenging. It's also challenging within systems that were never set up if we think about when the NHS was formed, these complex kids, like, you know, we've got a completely different business model now, guys, and it's tricky. So I have the utmost respect for people that are working in this system. So I was sharing this morning, and a parent said, I said, so we can think about these different places where people might be facing challenges. So it could be the child, the young person, it could be the service, it could be medical needs that mean that we can't use the positioning strategy we want to, could be the caregiver, it could be cultural. And she said, or it could be a buffet. And I will have 2 from service, 1 from caregiver, and 1 from cultural. And I was just like, yeah, it's not even just one of these complex challenges. It could be a whole mix. So this is not easy. But the rewards when we get it right are just huge. So last section, couple of resources to share with you. There was the one that I mentioned at the beginning, Clinical Excellence Online, which is a subscription service, but you can, there's, you know, different areas of expertise in different, you know, from different clinicians. You can search by practice, by age, by diagnosis, all sorts of stuff. It's an amazing platform. In terms of postural care and nursing resources, these 3, I have chapters in each of these. So nursing profound intellectual multiple disabilities, the At a Glance student book, and then this very recent one, the Essential Guide to Caring for People with Learning Disability and Autistic People, which was published just this year. So there's nursing specific information in each of those. And then there's a whole pile of, as I said, the internet's a wonderful place. There's stuff that's great and there's stuff that's not so great. So these are some of the things that I find that I share most often with the people that I'm working with. Last thing to say, so the Skies We're Under podcast is a parenting podcast for anyone who wants to know what it's really like to parent a child, a young person with complex disability. And I've put there, and I'm saying it out loud, it is not for younger listeners. The language is appalling. And yeah. Okay, so thank you for your time. And a real personal thank you as well. The one thing that I didn't really talk about was my own daughter. You saw her very briefly. My daughter is now 24 and lives with a complex brain injury. She was diagnosed with a malignant brain tumour when she was 6 years old and went on to have a very significant stroke when she was 9. So just a huge thank you to all the paediatric nurses. So I've met you and come across you in, like, just, you're everywhere and you are stunning. And my gratitude is endless. My email is there. Our office phone number is there. Email is the best way to get hold of me because I generally don't answer my phone to people that I don't know who it is, because it's usually someone trying to sell me something. Just email me and I will get in touch with you. And then there's loads of references and resources, but I'm going to share all of those. When the slides come out, Simon, all of those slides have got the links within. So it should be that people can just click on them and we'll be there. Oh, so in my corner it says together mode, and I've just looked and I look as if I'm in a like a fabulous I look like I'm on holiday and off at a theatre or something, which is marvellous. Okay, does anybody have any, I don't know, Bernie, what's your thoughts? Do you have questions? Fiona's got her hand up straight away.
Yeah.
Sarah, I'd like to thank you very much for doing this presentation. I have to say, some people probably think that it doesn't start till later because they've got a bit confused with time zones. But if you could send me a PDF of the slides, I'll get them on the ABPN website tonight. Thank you.
Absolutely. Fiona's given herself an action from today's meeting. Fiona's got with a time. So she's gone all smart on us. Anybody else got any questions?
Amy has.
I just wanted to quickly ask Sarah, what was your thoughts, I suppose, on perfect positioning versus function So obviously I know that they're having the positioning through the night
Yeah.
isn't really impacting function at the time. But for the children who, if you sit them in a perfect position during the day, they can't actually function as well as if they were in their normal functioning position.
Yeah. Okay, so a couple of things there. So the first one is that we can look at sleep as a function, and there is a wonderful infographic that looks at sleep. I'll also add that to my list of stuff. So the sleep infographic. Okay. And then we come to the kind of the positioning, the kind of perfect position. Yeah. I am very, very much of the opinion that children are children and function trumps posture. End of.
Yeah.
Yeah.
Yeah, I
So,
agree totally.
Yeah. It's really hard because there are posture police out there.
Oh yeah.
Oh yes. And it's difficult because and the reason that there are posture police out there is because they care very, very, very much. So trying to find a way to support people to have those concerns that they have addressed whilst respecting a child's right to function and be a child is a delicate balancing act. And what I would say is that there are very often children that I meet who don't have perfect posture during the day. So they may well be adopting positions that make your kind of eye twitch a little bit. But at night we can do some of the repair work.
Yeah.
Yeah. So okay. So you sit with an obliquity. So an obliquity, for people that don't know, is like one side is up a bit. First of all, I'd be saying get Sharon Sutherland in and let's be checking why that obliquity is there in seating. But let's say I've met kids who, to use their communication device and to get the control over their tone that they need in order to use their device, I've met kids who tie themselves in knots in order to give themselves the level of control that they need to then access, say, an eye gaze. Okay, so they're going to be doing that for a chunk of time. So let's think very carefully and be really proactive about nighttime. How do we counter that? Does that make sense? But the reason that people get themselves really passionate about something that you see differently is because they are passionate. So it has to be that conversation. What are your concerns? What is it that's really driving your, like the anxiety you have about something? Is that all right?
Yeah, absolutely. Thank you. And I will just say quickly, particularly to the parents on here, the podcast is fabulous. The three of you on that podcast is fabulous, and I think I've laughed and cried through every single episode. So particularly if you're a parent, do listen to the podcast.
Oh, thank you, Amy. I've overshared on the podcast. Go on, Bernie.
No, we've got Louise with a question, which might be our last question.
Yeah.
Just to squeeze one in.
Hi, thank you. I just wondered what your opinion is, Sarah, in terms of you saying lying time. So I have some patients who they get put into bed at like sort of 6, 7 o'clock in the evening, and they're not out of bed the next day till 10, 11 o'clock in the morning. Yeah. And it's trying to get the parents to see how them in a lying position, particularly with patients with scoliosis, that could be making it worse because they're spending it in their preferred position, and like you said, they're going to that preferred position. So when they go into their chair, they appear as if they're really uncomfortable, but obviously it's going to be uncomfortable for them because they're not used to being in that position. So I just wondered on what your opinion was in terms of if they can tolerate time out of bed and in their chair, should they be doing that?
I think you've got two parts of that question, I think, because part of it is around if a child is uncomfortable in their seating, and we meet lots and lots of children for whom the seating, again, complex. So I work in a special school once every half term, and the average wait for a wheelchair is 12 months. Mm-hmm. So once they've had their wheelchair assessed, they know what they need, then they wait for 12 months. And so we end up with a situation where kids are in things that don't fit. We don't wear shoes that don't fit.
Yeah.
You know? So what does a parent do when their child comes home from school and they've been in a chair that that they can't sit in all day, they're going to get them out of the chair and they need to lie them down. If they then don't have necessarily the support that they need in bed, like we can't, the option to go back to the chair isn't there. You can't, we can't be saying to people, you know, kind of, right, well, you're just gonna have to go back in the thing that doesn't fit. And it's a huge issue. And then the second thing that I would say is that there's a big responsibility that's loaded onto parents with regards to responsibilities to get this right. And the systems around them are not robust enough to support them well in this area. And that's not because physios, OT services are not working, you know, to like I work with the most passionate physios and OTs, but the actual systems around these families are not particularly robust or resilient. So we need to be just really careful about placing any sort of judgment on the action of a parent, you know, like kind of that they're doing something that's potentially harmful when actually the options we've given them are pretty limited. And I haven't answered your question, you know, like kind of I know I haven't specifically answered that question, but I think there's just a huge amount of work that we don't know, but we don't know the answers of what works well for families in this area. The research has not been done. It's a really, really neglected, considering how long kids spend in bed. It's such a neglected area. Yeah.
And every child's different, I suppose. But yeah, that's
absolutely
really helpful. Thank you. Thank you.
And with those kids that they're developing changes in their body shape, like we needed to have been there earlier, which I know is not an answer. Like go back in time.
I feel that a lot. I feel you see them now and you think there's not really much I can do now. And their breathing's getting worse. And you still try and you do everything you can, but you recognise that things should have maybe been done earlier.
Yeah. And that's on all of us, isn't it? That's on every single one of us here to go away and think about what's my influence on this system. And it may only be tiny and you may not be able to change everything, but who do I need the conversation with? Who do I, like I said, find out who that person is, buy them cake, sit them down. What are we going to do about this? Because these are the experiences of our nursing team as these kids are coming to us. And we know that there was stuff that should have been done previous. How do we catch these kids? I've been doing this the year I was born, 1976. Is the year that there was a paper published called Fulford and Brown, and it was linking the lying position to changes in body shape. So we are nearly 50 years into this and we're still not getting it right, which is not a reflection on people's like commitment. It's that we're just not there yet. Yeah. I'm really aware of the time and I've overstayed my welcome. So yeah, I can hang about for 5 minutes or so. If there are parents on the call who would like to catch up, then that's absolutely fine. I'm more than happy to do that. Simon's probably thinking, no, actually, I need to go home. But yeah, I got like 5 minutes if people wanted to stay. Is that all right?
That's fine. Thank you.
Thanks, Bernie.
If I'm going to, seeing as you've opened that up to parents, are there any parents here who would like to ask Sarah a question without putting anybody on the spot?
I've just realised that Angela's got her hand up as well.
She has, but just before Angela gets to go,
I'm not
assuming,
parent,
Angela, you're not a parent.
No,
well, you might be
a
parent, but you're not here as a parent. Sophie, are you a parent?
I am, yeah. I just want to say
Okay.
thank you for highlighting the struggle that we all have as parents with fighting the system, because it's a massive thing, and we always get the blame for, you know, insinuations that, you know, we're not doing enough for our individual, our child, our adult, and we are, you know. I'm a very passionate parent about my daughter, and she's had to wait unbelievable amounts of time for pieces of equipment that obviously are having massive effects on her posture and shape. She's got severe scoliosis due to a long hospital stay, where she was really poorly in 2019, and since then it's been, especially with the pandemic, everything was just forgotten and she was left without a lot of equipment that she desperately needed. And now they're saying that, you know, some services are actually saying that she doesn't fall into their category for, you know, the provision of the equipment at all. And it's just horrific. You know, I've just only won a you know, the ICB were refusing funding on a specialist bed, which, you know, I had a trial of, and I sent pictures and videos of the position that we could get for my daughter, and how we could achieve that, and how comfy she was. And they refused the funding time and time again, and luckily a charity obviously funded it for us. But it's been months and months.
Yeah. And Sophie, I'm so sorry to hear that experience. And for those people that are on the call that don't have experience of these equipment services, some of them are great, you know, in the speed at which they will operate, but it's very patchy across the country. Unfortunately, there are differences in what will be funded and then the speed at which the service can operate and all of those things. So I'm really sorry to hear that, Sophie. You have my email, and it's a genuine offer that if you need any support, then please do email me, and I am more than happy to help.
Obviously,
it's my pleasure.
Yeah, it's been really informative. So thank you, and thanks for
no problem, no worries at all. And Laura.
Laura.
Hello.
Hello.
Hi, Sarah. Thank you
Hiya.
so much. That was brilliant.
Oh, thank you.
Really useful, really informative. You made me cry because.
Oh, I'm sorry.
It's okay. Because you just wish that you'd done it differently. You wish you'd pushed more. You wish you'd, you know, done all the things that, and we did try, but like the other lady was saying, there's other things that are in the way. Like the system is just a complete nightmare. You know, you're waiting for things. The panel says no, or it just doesn't happen, or nobody even knows about it in the first place. And the other thing is, like you say, it's not just one thing. When you're fighting against or trying to care for a child that's got really complex health needs, that's exactly the thing. They're really complex, and this is just one tiny part of it. And to you, obviously, it's really super important, and it is. But you've also got, as a parent, somebody else who's got their bit that's super important. You know, a consultant urologist who's saying, you know, you must do this, and she must be catheterized this time. You must do that. And you must, you know, this is really important. It's super. And then you've got, you know, something else. You're juggling it all, basically trying to keep them alive. And sometimes things slip because you physically can't do it. It's really, really tricky. And like you say, when they've got other sort of functional things, like my daughter was in hospital for a long time, and she spent a lot of time poorly. And one of the things that she does when she's really in pain is roll over, you know, and that helps her. But that's helped create the situation we're in now, where a hip was coming out a couple of years ago. She was on the waiting list to have it done. Then we waited, and then she was ill, and now she can't have it because she's too risky. So my question is, sorry for the ramble,
not
is there anything you can do to get things back anywhere? I mean, is it like, you know, it's a lost cause?
You know, no, there is no such thing as lost causes, because so what we're thinking about is that no matter the age of the person, so whether this is children, young people or adults, gravity is always there. So unfortunately, it doesn't respect our birth certificate. And I'd love to say that when a child reaches skeletal maturity, then this isn't a problem. But it continues to be a problem. So what I would say, though, Laura, is firstly, number one, is that would have, should have, could have. I know, like personally, I know that they sit there. Okay. But somehow you just got to let them go, because they're not your friend, you know? And then the next thing is that you will have, at every single point along the way, you will have prioritized your daughter's care at that one moment in time with the resources you have. Yeah.
Every second.
Exactly. So whatever sat on the back seat had to sit on the back seat, because you know what the priority is. So you can let that one go as well. Okay. Like kind of you have, the decisions you've made have been good decisions. The next thing to think about is there anything small that's within our locus of control that we might do just to see what, you know, like, just a small change of position, a small change of support, but we will do it slowly, gently, and then just see where we are, because your daughter sounds very complex. So what we don't want is big changes, big ambition that sets everybody up to fail. Okay, so you've got my email as well. Just drop me a line and we can think about those tiny little things that might help us to just to get her more comfortable. Comfort's king. Yeah. Comfort's king, and then ambition comes
kind
up.
of half of the issue is that she's very, very movable. She's not a child that can only stay still, but that means that she gets in a pickle and she can't always get back out of it, and she gets into her preferred position, and then that has impacted everything. So it's tricky.
It is.
Thank you.
Tricky is the understatement. But yeah, pickles, we can, let's just have a look and see what sort of a pickle she gets into, and then see if there's anything that we can do. Is that all right?
Thank you for this.
Yeah,
it's
no,
really,
thank
really,
you.
really...
And thank you for being so honest with everybody, because people don't get to hear it all that often. Yeah, so, but thank you. All right. No worries.
We could carry on talking forever. I want to be able to let Sarah go. I want to say thank you to everybody who's joined us. It's been brilliant having parents as part of our webinar audience today. It's been brilliant having so many eager, interested people coming from different disciplines and from different parts of the world. And at this stage, I think I'm going to have to call it to a close. I can see that Emily has got a question, or Emily popped her hand up. If you can email Sarah, if you're a parent, then I'm sure she will get back to you. Okay, and Angela, you've probably got contact with Sarah at some point as well anyway, so I'm going to have to say stop before we carry on too long, which is not where I want to be. But thank you so much, Sarah. Yet again, you have been brilliant, so thank you so much.
Thank you.